Okay, as I mentioned, I have the great good fortune today of introducing our speaker, Troy Ward. He is presenting today on client-centered collaboration, professionals uniting for brain injury support. Troy is a licensed mental health counselor and a certified brain injury specialist, and he has been serving clients in private practice since 2019. He became involved with the brain injury community through his past work with REM Iowa Community Services. Currently, TBI survivors make up approximately 25% of his counseling practice. Troy lives in Solon with his wife, son, daughter, and their naughty beagle. Please welcome Troy Ward.
Thank you, Courtney. I appreciate it. The kind introduction. My name is Troy Ward, as Courtney mentioned, and we're going to be talking about collaboration today. So specific to individuals with brain injuries, a lot of this information I think we will find is kind of more generalizable to people in general as well. As Courtney mentioned, please, as we're going through today and having this discussion, I guess that's kind of what I'm hoping for, is a bit of a discussion. So if there are questions or comments or conflicts or anything like that, please do put those into the chat, and we can hopefully kind of address those as we go here. So objectives, kind of starting at the beginning, kind of a narrow focus here. So all about this collaboration stuff. So we're going to talk about challenges for brain injury survivors that might get in the way of collaboration, as well as challenges that come up for professionals in these different realms. We're going to talk about benefits of collaboration, kind of the why we should be concerned with this in the first place, why this can be helpful and beneficial, and then concepts, strategies, ideas related to how do we collaborate, how do we kind of bring these things together. So first of all, addressing the why. Why think about this? Why bother with this collaboration stuff in the first place? Professional collaboration tends to benefit the individual served. And in addition to that, it tends to benefit us as helping professionals. We'll get into that in more detail here, but basically it's useful. It's good for everybody who is involved. Consistency in care and well-rounded approaches, this kind of it takes a village type of mentality that we will be discussing, this tends to lead to better outcomes. This tends to be, again, I'm repeating myself here, this is useful, this is beneficial for these people who are served. So that's kind of the why here. This consistency, this kind of joining together in approaches tends to lead to good outcomes for people. That's kind of the why. That's what we're going for. So addressing some of the challenges, some of the issues. First of all, thinking about issues or challenges for TBI survivors. One issue might be with memory. If I can't remember what provider A told me to tell provider B, I'm not able to share that information. There's going to be a gap in services. There's going to be a breakdown in that way. That can get in the way of providing quality care, providing quality services for these folks. Issues related to communication. If I cannot communicate effectively, again, if there's a memory deficit there, communicating effectively might be a challenge. This might be something that people run into. If I'm not able to advocate for myself in an effective way, again, there just might be breakdown in the quality and the types of services that I am receiving, type of assistance that I am receiving. Another challenge might be emotional changes. To speak to this a little bit, if an individual who's living with a brain injury, if they're dealing with changed emotions, with more intense emotions, with more more variety, lability within emotions, this can get in the way of effectively seeking out the services, the assistance, the help, the collaboration that they need. This kind of having a difficult difficult time conveying this, and I guess that kind of exemplifies the point here. If an emotion can present difficulty in that way, that very simply that can create a barrier. Instability or inconsistency in support structure. Thinking about individuals who might receive services within a more structured setting. So like if I've got somebody who lives in a group home, they're going to have all of those services kind of built in: case management, staff that are getting them to and from appointments, to and from services, that sort of thing. That can be kind of the ideal. However, there are many individuals who kind of don't fit into that neat and tidy frame. This can lead to this instability or this inconsistency. So for example, if I have a family member who is the primary person who gets me to and from my appointments or to and from where I need to go, they might, like if they're ill or if they have other responsibilities that they have to tend to, that might lead to a breakdown in consistency. There's also a relational aspect to this that can come up. If, let's say, for example, that my brother is the person who takes me to all these appointments. If my sister has to fill in because, again, he has other responsibilities, let's say that they just don't get along with each other well. If there's a relational issue there, again, there might be information that is not shared or information that kind of gets lost in the churn. So this inconsistency can kind of lead to these sort of breakdowns. Issues related to self-advocacy. And again, this is kind of encompassed in many of these other issues, but if I'm not able to convey what I need appropriately or convey what I need accurately, the people that I'm working with, the people that are working for me, are going to have a challenging time meeting my needs. I can't meet your need if you don't tell me what your need is, or if you're not able to tell me what your need is. So again, kind of opening up to discussion, I wonder if we have other challenges that we might see and we might run into. And Courtney, I'm not sure how to convey this through the, if you'd like to convey information through the group chat, or how you typically handle this, but yeah, just kind of welcoming feedback in that way if there are other challenges that people see or have ran into. And if not, that's okay too. You can move forward.
A comment came through, Troy. I think it was directed to just me, but meant for the whole group, using basic language so there isn't confusion.
Absolutely. Absolutely. We have to make sure that in with relationship to communication, I want to be communicating effectively. I want to make sure that, I love the sound of my own voice and all of that good stuff, but I want to make sure that the other person on the other side of that interaction is able to understand the information that I'm conveying. So that certainly can be a challenge with relationship to these issues. So we have challenges for survivors. There we go. We also have challenges for professionals. A big one is, again, in the realm of communication, very much the same thing here. There can be all sorts of things: misunderstandings, miscommunication, missed communication that can take place that can really get in the way of collaborating effectively for the individual. All of these kind of tie together, so I'm kind of overlapping, but this bleeds into this issue of time. As a professional, I have a certain amount of time in my day and in my week where I am in that setting. I am on, I guess, professionally. The other side of that coin is I also, in order to be effective at what I do, I have to kind of have boundaries with my workplace. I have to leave work at work. So when things kind of have to fit into that frame of time, again, there can be things that get overlooked. There can be things that get missed or get miscommunicated or undercommunicated. This idea that time is precious, again, we only just realistically, we only have so many hours in the day. We only have so much resources that we can give in that way. So this certainly presents a challenge. I have to be thoughtful and I guess proactive in the way that I utilize and manage my time. Then we run into this concept of silos. So a brief kind of description of what I mean by silos in the professional setting. So these are structures, uh, not like literal physical structures, but structures among people. So that this can be within an organization. We'll just use the organization example because it's an easy one. Within an organization, I can have different groups of people. This might be different departments. This might be different social groups. This might be groups like based in seniority, you know, the people who have been here for a while versus the new people. We tend to kind of break off into these groups. And what can happen is one hand is not talking to the other hand. We get siloed. We become isolated in this way. This can happen within an organization. This can also happen within the different areas, the different realms that individuals with brain injuries have to navigate. If my psych provider is not speaking to my medical provider, is not speaking to my therapy provider, again, there can be information that gets lost, gets kind of misplaced within that churn. There can be breakdown in this way, and that tends to be detrimental to the individual who is seeking these services. So silos can be, again, just a big detriment to this idea of connection, along with these other issues that get in the way. So again, opening this up, I wonder what other professional challenges we might see or we might run into.
Troy, Megan shared one saying, don't misinterpret their behavior as intentionally defiant.
That is an excellent point. Again, if an individual is struggling with, I think it's back to communication, conveying how they feel or conveying how they think effectively, that can really lead to a challenge. And if we have this interpretation that, as you say, like this person is defiant or this person is manipulative or whatever, well, I've labeled that person, I've stigmatized that person. And if that, thinking about this collaboration process, that can be really dangerous because that can sort of bleed over into my colleagues, into my peers. If I have this viewpoint of this person and then I share that misinformed viewpoint with somebody else, that's just a detriment to the person being served. But stigma labels, we don't like that stuff. That's not useful here. So identifying some of the challenges, and again, we've got to fit this in the time we have here. I'm sure there are many more that would apply in this way. So to take you guys on a little bit of a tangent, I want to talk about a couple of different terms that might be useful to this discussion, and then we'll kind of come back around, get back on track here. So first of all, some fundamental stuff. So starting with person-centered language, and then the medical versus the person-centered model. So person-centered language, a quick description is I can define a person by a label. So for example, when Courtney introduced me, if she introduced, this is Troy Ward, he is a somewhat accomplished fisherman, and he's going to be talking to us about collaboration today. You guys would probably be like, what does that have to do with anything? I'm a fisherman. I like to fish. However, that's only a narrow slice of who I am. It's a small part of my identity. It's a piece of me. So when we use the label to define the person, like the one that I hear often in what I do is individuals with borderline personality disorder. We refer to them as borderlines. We kind of put this stigmatizing label on the person, and then again, that I define the whole person by this narrow label. That's not reality. Reality is people are people. I have, like again, I'm a counselor, I'm a husband, I'm a father, I'm a fisherman. That's a part of me too. But my identity is more complex and more wide than just the one label. So person-centered language, I always want to be putting the person first. I'm talking about individuals with brain injuries or individuals who are survivors of brain injuries, individuals with a personality disorder, individuals with a mental illness. I want to put the person first in how I am referring to them. As simple as that. So this idea of the medical model, again, relatively simplistic explanation, but the basic idea with this is that the medical model sees ailments, sees issues as like problems to be solved. So if I go to the doctor and my leg is broken, they're going to help me fix the problem or help me solve the problem. They're going to set the leg and put a cast on and all of that stuff. In some circumstances like this, the medical model is appropriate and the medical model can be useful. I identify the problem, I solve the problem. However, for individuals who are survivors of brain injuries, especially, the medical model doesn't tend to fit. I'm not an issue that needs to be fixed. Or so something I've heard a time or two is I'm not broken. I'm just a person. That's reality for a lot of these individuals. And again, this goes beyond the brain injury realm, but this applies here very closely. The medical model doesn't tend to fit. The medical model of conceptualizing and seeing the person doesn't tend to fit these types of cases. The person-centered model, putting the person first, addressing their identity, addressing what's important to them, this tends to serve the person more effectively, and this tends to give a more holistic, more realistic version of who this person is, what they bring to the table. Something I was thinking about in putting this together is over time, I've worked with a couple really good case managers who are really effective at if they're treatment planning or if they're having discussion, they're all about putting the person first. So in the treatment plan, for example, they're addressing, this is the individual, this is what they like to be called, David or Dave, that sort of thing, identifying the language that the person wants to use and what that wants to have used about them, identifying what's important to them, what are their likes, what are their interests, what are their goals for the future. When I can kind of bring my mindset in that direction, put the person at the center, put the person first, it's just very simply, this is useful for professional collaboration. It kind of gets us all on the same page, gets us all looking at the same or at least a similar picture. So next term here, validation.
Troy, if I could stop you for a second, I think a really great comment just came in from Megan on your last point there. She said that she interestingly has patients who prefer to use the label, even with her educating them on person-centered language. And she made the comment that sometimes our patients just want to be validated, not fixed.
Well, thank you for the lovely transition. Speaking of validation, I completely agree with what you're saying. It's all about how the person wants to be viewed and how the person wants to be perceived. And there are cases, there are circumstances where the label can be, it can be useful in that way. It can be effective in conveying that piece. The important part is checking in with the person to verify how do you want to be referred to? How do you want to be thought about? So leading to validation. So first of all, just kind of dictionary definition, because we use validation in our day-to-day language. Validation can mean approval, acceptance, confirmation. I validate that the thing is accurate. I validate that the thing is true. That's kind of the everyday language approach. Validation as a concept, well, I describe this as a counseling concept. This shows up in all sorts of different human services related realms, I think. The definition looks something like this. When I can validate that a person's thoughts, feelings, or behaviors make sense and is understandable within their own circumstances. That's what validation looks like. I'm verifying that whatever is going on with the person, thoughts, feelings, behaviors, they make sense. They're accurate for that person and for their circumstances. validation can be powerful. I don't have any research to back this at this moment, but I would make the argument that validation, feeling validated, is just about the best feeling you can feel. When I feel seen, when I feel understood, that's a good feeling, to say the very least. But within these types of settings, when we are collaborating, we are working together, validation can be a powerful concept. Because when I can, as a professional, when I can show that I can understand, I get where you're coming from, or I think I get where you're coming from, that can be really useful in joining together with the individual. So a little bit further on validation, building the concept up a bit more, I don't have to agree with the person. The person doesn't have to be factually accurate in order for me to validate them. Again, thoughts, feelings, behaviors are the things that I can validate. So let just a simple example. If we're having a conversation and you're saying, oh, this beautiful blue sky that we have today, which not really, but bear with me. If we're talking about, again, the sky is blue and the sky is beautiful, if I am stuck on, I'm dying on the hill that the sky is green, that's all there is to it. The sky is green. You can't validate that because that's not factually accurate. However, again, I can validate, maybe where the person is coming from emotionally. Maybe that feeling that is associated with that statement. Maybe I can validate the thinking that is associated with that. Validation is all about finding things to kind of join with the person on. So the Churchill quote here that sort of applies in a sideways way. So tact is the ability to tell someone to go to hell in such a way that they look forward to the trip. Kind of a loose association here, I guess, but I think maybe we can relate this. When I can validate someone, even if we're on opposite ends of the spectrum, even if we're in disagreement, I can find that's what validation is all about. I can find that common ground with that individual. That can be useful in this joining process. That might be working with a brain injury survivor. That might be working with another professional. If we get at odds at things, or if I'm in my little silo and you're in your little silo, and we're trying to come together, sometimes there can be conflict in that way. Validation, looking for that kernel of truth, hopefully finding that kernel of truth this can be a powerful tool in this joining process.
If I could stop you again, Troy, there's lots of really great engagement in the chat box. Megan commented saying, going back to your point about boundaries, she's had patients tell her that she's not validating them if she doesn't take on their feelings. And for example, they are mad about something, so I should be too. And she explains to them that she can understand why the event is upsetting to them, but that it's not her event to be mad about.
Yeah, that's a great example of that joining. I don't have to agree with you to validate you, or we don't have to be on the same page with whatever thing there is in order for that validation to take place. I can so that validation is a form of empathy, meaning I'm taking on someone else's perspective. When I can kind of see through your lenses in that way, I can focus on, and I want to be focused on where the commonalities are. What can we agree on, or what can we see in common? And yeah, this can be just a great example. So final kind of fundamental concept here, the idea of informed consent. So again, a brief definition to go along with this. So informed consent is consent by a person to undergo a medical procedure, participate in a clinical trial, be counseled by a professional such as a social worker, a lawyer, mental health counselor, after, this is the key part, after receiving all material information regarding risks, benefits, alternatives. So putting it more simply, informed consent is making sure that the person receiving the service is agreeable to the service. They are actually wanting the service that is being offered. This this appears in many medical settings. This appears in counseling. It's kind of a standard practice here. We'll get back to later on here how I kind of relate informed consent to this process, but just wanted to touch on this a bit on the front end because again, this kind of ties into validation. This is this process of agreement, this process of kind of getting everybody on the same page, agreeing that, you know, this is what we're going to do. This is the direction that we're moving in. In this collaboration process, well, I'll mention this a bit now, and then again, we will come back to this closer to the end. This has me thinking about like information releases or ROIs. We do lots of information releases in professional collaboration because I want to be able to, just very simply, I want to be able to talk to collaborate with the other professionals who are involved in the process for the person receiving services, excuse me. The informed consent process, this is an excellent time to kind of present this approach to the person, basically letting them know I want to be in contact with these other people because I want to see the whole case here. You know, I've got my area that I specialize in, the service that I'm providing, but it's going to be helpful for me in working with the person and thinking, again, having that more well-rounded picture.
I have a comment and a question that have come in, Troy, if it's okay if I share those real quick with you.
Please.
First is a comment. I am a therapist and a brain tumor survivor, and it has made me even more sensitive to validating, listening, and acknowledging feelings. Being in OT, PT, and speech herself post-op, I have new sensitivity to involving the patients in treatment and validating their concerns. Thank you, by the way, for sharing that lived experience. And then we have a question that came in. In your practice, Troy, how often do you have to refresh your parents on informed consent, especially if there's a memory impairment?
Well, speaking specifically to the memory impairment part, that tends to present challenges, certainly. And there's not, I wish I had just a nice example to share. There's not really a nice example to share because, you know, individuals tend to differ from one another. However, with relationship to, so if we're dealing with, you know, the brain injury deficit of short-term memory loss, for example, or just issues with memory, just to be kind of broad, we do tend to revisit informed consent pretty often throughout the process. And that, I guess, to be as specific as I can be, not necessarily like the informed consent process of like, you know, we're not talking about confidentiality and talking about privacy and talking about client rights and all that stuff. Not necessarily that sort of stuff, but really getting back to like the treatment plan and the treatment goals in that type of setting. And it can be really useful in addressing some of those deficits to continue to go back to that plan, that kind of structure that's been built. Because so in the counseling setting with a treatment plan, that is a collaborative process between the therapist and the client. And then you know, whoever else they have within their support structure, whether that's family members and in some cases that might be other helping professionals, like, you know, medical folks, for example. So those goals are established together by the team, and yeah, going back and revisiting those goals over the course of time can be useful for many reasons, but the big one with relationship to memory related stuff is it's just kind of keeping things on track, making sure that we are where the person needs to be, if that makes sense. So, okay, so some of the fundamental stuff. So now we get to, what does this process look like ideally? So professional collaboration with folks with brain injuries. Where we want to be focused is, again, back to being person-centered. So this idea of nothing about me without me, I think, shows up here. So of course, the individual receiving services, they need to be at the center of this process. what we've been discussing with relationship to validation, I think this is again an important piece of this process with being person-centered. I want to ensure that, as we've been discussing here, I guess how I think about this through the therapy frame is I need to be where the person needs to be. So I have my own ideas about treatment plan, and these are the goals and these are the objectives we should be addressing, and here's my clinical impression and all that. However, if I'm not, if just very simply, if I'm not addressing what the person needs to be addressing, if I'm not pointed where they need to be pointed, I'm probably not going to be as effective. So that kind of contributes to this person-centered process here. So this, again, the beautiful cliche of it takes a village. It's a cliche because it's so true. This group effort it has many benefits to it. When professionals can work together, when we can collaborate together, there is this joining process, and there is this, again, back to validation, there is this validation that can take place for the individual. If I feel as though the people who are helping me, the people who are working with me, are kind of on my team, on my side, having my interests in mind, and they show me that by, again, validating, this is how you want to be spoken about, this is how you want to be spoken to, these are the things that are important to you. When they can show that and reinforce that, there's this mutual benefit that takes place here. So for the professional, there's this concept of learning from each other. Very simply, I don't want to have to reinvent the wheel. So I guess a brief example, if I have a brand new client in my therapy setting, and I know that they have been seeing their primary care doctor for years and years and years, and they have a great relationship together. If that's something that comes up at intake, I'm going to be filling out that release of information. I want to talk to that doctor because I don't want them to run the treatment process in therapy, but I do want their perspective. I want to have their more well-rounded understanding of, who is this person? What's important to this person? What do we need to be focused on with this person? I want to have that support in that way. That's useful for me as a clinician. I don't have to reinvent the wheel. And that, again, that's mutually beneficial. It's good for the person being served as well. So then I have this final little blurb here. Consistency is calming. What the heck does that mean? So consistency, if we think about routine, like I have my morning routine. I get up and then I do this, 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 the same way every time. When I have consistency in that way, I don't have to worry about what's coming next. I don't have to be uncertain about where am I going to be, what's going to be happening. Again, thinking about those brain injury deficits, if there are issues with memory, if there are issues with cognition in that way, this could cause issue in following through with taking care of myself, like if I'm seeing a provider, for example. So an example with this, I had a previous client who they were apprehensive about attending a medical appointment, and this medical appointment was very necessary for them. They needed to go and have this procedure done, have this taken care of in order to maintain and to improve their health. They were very anxious, very worried about this, and this led to avoidance of taking care of this thing. I realize I'm speaking vaguely, I'm sorry, but what was beneficial in this situation was being able to have a conversation together. First of all, myself with this client, having this conversation together about, okay, this is the concern. This is what you need in order to feel more comfortable with this concern. So they needed things to kind of, within this appointment, they needed things to kind of slow down. And they needed the approach to be a little bit more, I guess, gentle in that way, just a little bit slower, a little bit more not rushed, not pushy. When we were able to identify that and verbalize that, then they were able to take that to their doc and again identify that and verbalize that. The doc was able to slow this down, make this a little bit more consistent. So there was a little bit of a buildup to this this particular procedure, and they were able to follow through with this. They were able to have a better outcome. So consistency is calming in that if I know what to expect, I don't have to worry about what to expect. And this in the practical application here, this leads to hopefully more consistency, more follow through for the individual in what they're needing.
Troy, this is Courtney again. I'm telling you, I feel like I'm playing double Dutch jump rope jumping in here. There's so much engagement in the chat box. It's fabulous. It speaks to how necessary this topic is for discussion among professionals. There was a comment in regards to being person-centered. Megan shared that she tells the folks that she serves what we are going to work on versus what you are going to work on, that we're not doing something to them. Like you said, we're aligning and we're joining with them in the process. And then also saying that, you know, what they want to work on may not be the same as what we see them benefiting from working on, and wanting to clarify that point, because that frequently comes up.
Absolutely. The individual, first of all, we versus you, that's a great point. When I can make this in the way that I'm describing it, in the way that I'm discussing it, when I can make it a collaboration, it's us approaching this thing. Again, that can just be validating for the individual. I'm joining together with them. I'm showing them that, you know, we have this commonly shared thing that we are doing. It's not this person all by themselves. There is that support there. That can be hugely useful. Again, reemphasizing the point with the second part of that comment, it's important to be where the individual needs to be. So there's this example within counseling that I'm sure can be generalized elsewhere. It's this idea that it's not helpful for me to work harder than my client. So what I mean when I say that is if I, you know, again, my clinical impression is we need to be working on ABC because you are going to see these 5 or 6 wonderful outcomes from this. If that's not where the person is, if they're still contemplating changing, or they're not interested in change at all, I can't take that person by the hand and lead them to, okay, this is what you have to do. I can't take them there, because as soon as I let go, they're just going to go back to right where they were. The person's process, the person's work, whatever this may be, it's their own process, and it's a little bit complicated because I was just talking about joining. So I have to join with the individual. This is true, and at the same time, they need to have that independence in kind of guiding and directing where they, again, we need to be right where they need to be. That's an important thing here. So this all kind of leads to this kind of, again, I'm hoping there's more talk in the chat box here. This leads to this kind of nebulous idea that I've been thinking about, and I want to be clear that this is kind of a first draft presentation here. So this is again kind of a loose idea. So I would welcome lots of discussion here. So as I mentioned earlier, if an individual is in more structured services, like a group home kind of setting, they have case management, they have staff, they have other supports in the community that someone kind of coordinates and tends to kind of pull together on their behalf. And then they make sure that they get to and from appointments. They have all of that assistance that is kind of built into the system. That's great for the people that exist within that system. And again, we have to acknowledge that for many people, I'm not living in a group home. Maybe I'm living independently in the community. Maybe my support structure is not as well defined, or maybe I just don't have that many supports. So I've been thinking about this idea of this key person. we have this key person again with some of these more structured settings, but I wonder if I don't know how to precisely frame this. So again another example, uh, a previous client had a physician that they were working with that they saw for years and years, and a very specialized, like, not a general physician, but like an ear nose throat, like, only works on this very specific slice of things. So even though they had this very specialized area that they worked in this case, this physician, they took interest in this individual because they were exposed to some background information about this person. So again, they took interest in this person, and in an appropriate way, of course, but they began to kind of build a relationship with this individual. And what this led to is this particular physician, again, even though they've got their narrow little lane that they're working in, they became this kind of key person for this individual being served. And what this led to is this led to, again, more sort of professional collaboration. The doctor would reach out to the other medical professionals that this person was seeing, for example, and would collaborate with them, would share information. They would reach out to the mental health people that this individual is working with. All of these different lanes that this this one incidence of this person kind of taking interest, and then thereby it's not like they were running the show, they're not like the treatment planner or anything like that, but they were just able to kind of open up these avenues of communication, and in that way they kind of served as this key person. The other prime example of this is neuro resource facilitators, the folks with the Brain Injury Alliance. I think that the people in this role serve as the prime example of what this collaboration should look like. So stealing directly from the Brain Injury Alliance website, neuro resource facilitators provide brain injury specific information and resources, INR. They enhance natural supports, and this is the key part, enhance natural supports and provide linkage to appropriate supports, services, and community resources. That linkage, connecting the person to where they need to be, connecting them to other professionals, connecting them to resources. That's the key here. And in the piece in parentheses about, identifying a key person or possibly a key document. Again, thinking about the more structured settings that people can be in, there tends to be a treatment plan that is worked off of. And like in the counseling setting, again, there tends to be a treatment plan that is worked off of. And that treatment plan isn't going to apply everywhere. Like, again, the mental health stuff, like I'm not going to take that to my primary care and that's going to apply. But I'm thinking more about the communication, the sharing of information that can come from something like that. So one more example with this, part of my intake and my personal intake informed consent process is talking to clients about, identifying, okay, who are your people, who's the treatment team, who's your docs, who's your med providers, that sort of thing. And then I have just like a form letter, just very simply like, I'm Troy, I'm a counselor, we have a mutual patient, please reach out to me if you'd like to, let's connect. So just this basic, like, establishing communication type of letter. So something like that can serve as, again, just a means of opening up this communication. So again, it's difficult to be really specific about this because people are individuals, people are different. But I guess in thinking about all these different ideas related to collaboration, this is kind of where the thinking leads to for me. So at this point, again, I'm curious what people's thoughts are here, what sort of questions and so on maybe this brings up.
A comment did come through, Troy. Really good advice, more advice actually, suggesting that when you connect folks to services, if you can, being specific with how long they can expect to hear back, is that will increase their cooperation in the process. So good advice there.
Certainly. Certainly. So, yeah, I think again, where the process leads to, where the process leads to ideally, is opening up these channels of communications. Again, thinking about silos from earlier, avoiding these silos where it's possible. So benefits, again, back to the why. Why is this important? A couple things here. Relationships feel good. Professional relationships do too. The thought here is that, again, thinking about what we've been discussing related to validation, related to the person-centered, person-first type of approach. When we connect, when professionals are able to connect with the people that they're serving, that tends to be a validating experience for the individual. It tends to feel good. I don't necessarily have a research study to back this up, but I think that that positive feeling, that validated feeling, will likely lead to increased accountability, increased consistency, and increased follow through related to these types of collaborations. So there's this whole relational aspect. For professionals, there's this mutual learning, this growing understanding, this mutual growth that tends to happen. For example, in working together with Courtney on various NRF type of situations, various collaboration, we've built relationship from this, and this mutual understanding, this mutual growth. She shared things with me related to clients that have benefited them, that have benefited my work with them, and that I think that's gone both directions. That's an example of this. This kind of leads to my little axe to grind. In the state of Iowa, there's a shortage of clinicians, or there seems to be a shortage of mental health clinicians who are able to work with survivors of traumatic brain injuries. There's this sort of stigma that I see. They see the traumatic brain injury label and they automatically go to, I can't do that. I can't support that. The reality is, people with brain injuries are people. And counselors, like that's what we do. We work with people. We address needs, we address deficits, we work together on these things. Again, if we go back to the person-centered model, if I first think about the individual, my thought would be that if this could be shared in some way, that perhaps there'd be more of this resource. Perhaps there wouldn't be as much of a shortage of these types of clinicians. If this kind of viewpoint could be kind of changed in this way, it could be built upon. I mentioned this earlier, being able to avoid reinventing the wheel. Again, professionals, we're busy, we're time limited. There's a lot going on, a lot of plates to keep spinning. When I can benefit from somebody else's work, I mean, that's, it's kind of a blunt way to put it, but I mean, that's the truth. When I can benefit from somebody else's work, from somebody else's insight, from somebody else's relationship with the person, that's good for everybody. It's good for me as a professional. It makes my job a little easier. It's good for the person being served. Mutual benefit here. This idea of momentum. I've seen this example play out a few different times. When someone has success working with someone in a professional setting, we can begin to build momentum in that. If the therapist is working with the individual, has a good relationship, that can lead to pairing with these other resources. I can get them going with the Brain Injury Alliance. I can get them going with the new physician. There's momentum in that. That can be useful. So again, opening this up a little bit, any other examples?
I have one, Troy, and then I'm going to take folks off of mute so that they can jump in as they like. A comment that came in is from Megan, and she said, when you develop rapport with the people that you serve, they don't interpret accountability as punitive. And in her experience, she's found that they actually enjoy it.
Absolutely. Absolutely. When there's that strong relationship there, I can ask a lot of people that's yeah, I don't know how else to put that. The relationship here is extremely important on the person to person level, and in all of these interactions that we're describing between the professional and the individual, but professional to professional as well. If the relationship can be focused on, again, that validation stuff, if I can focus on the things we have in common instead of the areas where we differ, that's good for everybody. So I have this example, and I'm concerned that this might be this might stretch us a little thin time wise if we have other questions and so on we want to get to. So I guess I'm kind of showing my amateurness here, Courtney. What do you suggest?
This is not at all. This is a good problem to have. Honestly, Troy, this is the most engagement I've seen for a webinar and a chat. So this is fantastic. I will, I guess, help you open it up right now for anybody who has a comment or a question, maybe that you want to throw in the chat box. We'll pause for a second. Otherwise, Troy, considering that it's 12:52, you can absolutely do the case study if you want. I'm just looking to see if anything pops in.
Okay.
I don't see anything yet. If you want to, we still have some time if you'd like to run through this.
Okay, absolutely. So
This is Megan, really quick.
Oh, go
yeah,
ahead.
please.
Troy, I didn't know if you were planning on posting your contact information, but I would be interested in maybe bouncing ideas off of you or something in the future, because I've got a few that I have an idea on maybe what to do to help them, but I just am always trying to educate myself and be more informed. So I was hoping maybe we could either you post it or I could post it or whatever.
Absolutely. So here's my email, and
I'll
then
drop it in the chat. I'll drop it in the chat right now too, Troy. So
Okay.
that if you want to bring back up your other PowerPoint slide, that you're able to do that. I'll put it in there.
Okay, perfect. So this example, so talking about Gary. So some background information. So Gary's a TBI survivor. Some of the deficits he experiences, issues with memory, issues with organization, staying organized, and a lack of experience. So what I mean by that is his brain injury was relatively new to him, and so he's kind of navigating the ups and downs, the changes that are associated with that. Still kind of settling into the new normal. Gary's also a childhood trauma survivor. So this led to issues related to mental health, some mental health diagnoses, and kind of a secondary issue, kind of some antagonistic types of relationships, types of interactions with medical providers. Kind of knew that he needed to go and receive this help, and at the same time, again, felt kind of traumatized, felt kind of triggered by this, kind of averse to these to following through with these sorts of things. And additionally, chronic health concerns. So unfortunately, lots of medical appointments, lots of follow-up, lots of complicated like medication procedures, and like different stuff in that area that he had to navigate. With these deficits, long story short, this was very challenging for this individual. The follow-through related to the medical stuff was really poor, was really lacking. And so this led to, increasing health issues. The chronic stuff was not getting better, it was getting worse. The chronic stuff was not staying managed effectively. Lots of issues here. So through this is a client who came to me through collaboration with the neuro resource facilitator. They suggested therapy services. This led to a relationship with me. This led to identifying these issues around I'm not compliant with med appointments because of this background stuff, because of my trauma history, because of childhood stuff. This led to these discussions. This led to discussions about self-advocacy. This led ultimately to a discussion with the primary care provider. So we had a meeting together, and this led to all sorts of collaboration. The primary care got involved with the med provider. The med provider came loop back with me. There's all of this talking and collaboration back and forth. For the individual being served, this led to increased self-advocacy. They used to really struggle with advocating for themselves in different settings, in the medical setting. Now they're getting pretty good at it. They're getting pretty consistent at it. Increased consistency, showing up to these appointments, not avoiding these appointments, not putting off these appointments, not having these negative interactions with providers that don't want to work with this person anymore. This leads to ultimately improved health outcomes for this individual, both physical and mental health. They're doing a heck of a lot better due to this professional collaboration. And this is an ideal example. This is what this leads to, ideally. And again, as we've discussed today, people are complicated. People are individuals. So each and every example is going to be a little bit different. But ultimately, this is what we're going for. Having someone who is willing to open up the communication, open up the means or the chains of communication, and then allowing that to kind of grow from there. And additionally, final thing here, I guess, there's that client involvement. The person being served is part of the process. When they're part of the process, again, they're having these good outcomes. They're more able and more I'm losing the word here, but they're better able to advocate for themselves. They're better able to be consistent in their own care, in their just kind of that mindset that's associated with that. I want to take care of myself, and I can overcome these barriers in that way because I have somebody who's on my side. There's that validation. I feel understood. I feel seen. So that's kind of the culmination of all of this. So all of that being said, so I guess where this all leads to, again, just kind of reviewing. In the informed consent process, I want to be seeking out those releases of information. I want to, as much as I can, be collaborating with the other professionals who are involved with the individual. One final thing with this is as I mentioned earlier, that example of kind of having a form letter, just identifying, I'm the provider, we have a mutual patient. If you'd like to, let's talk. That having something very simple where all I've got to do is get in my Word document, change the person's name, change the date, and then I can put it in the mail. It's not this long involved process. Doing these things to be able to kind of streamline that communication as much as I possibly can be useful, can be helpful here. So all of that being said, I very much appreciate everyone's attention today. And if there are other questions.
I've made it possible so that folks can hop off mute now if they want, if there are any other comments or questions for Troy.
This is Megan again. This isn't really a question, but just there have been times where I will get discouraged when I don't have a doctor, a therapist, med provider, whoever who doesn't want to collaborate, but I just try to tell myself, maybe I just have to build that relationship with them more. Maybe I need to define my role a little bit clearer, but I'm wanting them to understand I'm not trying to maybe overpower what you're doing with the patient. I'm not trying to suggest anything that's out of my scope. It's just, I just want to make sure that we work together, because there are times where patients share things with me that they don't share with the other people.
Mhm.
And it's just difficult if they don't know about that information because they're missing out on treatment options completely if they're not considering all those factors that make up the person's issues, whether it's homelessness, food insecurity, whatever is going on. I just believe in treating the person as a whole, and we can't just focus on, in this case, TBI. You have to look at all the other factors that are at play.
Absolutely. Absolutely. And that kind of again, like staying in my lane, staying in my silo, that can be really challenging to overcome. And I guess I would just encourage you to remain persistent with that. And yeah, it can be really frustrating when I do have valuable information to share, and it's not just as you were saying, I'm not trying to like overshadow anybody else's work or muddy those waters, but that communication can be mutually beneficial. It's good for everybody.
Anyone else? Well, Troy, I just wanted to say again, on behalf of everybody, thank you very, very much for presenting on such a always timely topic. It's evidenced by the amount of engagement we had today, how necessary this topic is for us as professionals to continue to talk about. So thank you for sharing your time and talent with us. It's greatly appreciated. And I just want to remind everybody too, I made sure to share the evaluation link multiple times, just to make sure everybody was able to grab that and provide feedback, if you're able to do so. And then this was recorded. So by the end of the day today, I will have it uploaded to our YouTube site, the Brain Injury Alliance of Iowa YouTube site. So you can rewatch it if you need to or share it, but that will be here by the end of the day.
Courtney, do you guys have a list, or can you put together maybe a list of future trainings you're going to be offering? I found out about all these great brain injury webinars through the Iowa Board of Certification for my KDAC. And just any other opportunities I would like to be, I don't know if you guys put people on a list or whatever.
Yeah, Megan, why don't you go ahead and drop, and anybody else too, drop your email in the chat and I'll grab it before I sign off. We do have, I think they're weekly now. Weekly. We have a monthly newsletter, and then we have, I think, a weekly email that highlights any webinars that are coming up, support groups that are meeting that week. And then on our website, we also have an events tab that will lay out upcoming webinars. But I can absolutely get you on a list so that you get those with some advance notice. Yeah, if you just want to make sure to drop it in there, and anybody else, I'll grab those emails.
Thank you.
Yeah. Anything else before we conclude today's webinar? Okay. Well, I think, Troy, if that is it, I will go ahead and stop the recording. I'll get that uploaded. And thank you again so much for sharing your time and experience with us, Troy.
Absolutely. And again, thank you to everybody for showing up and for participating today. I appreciate it.
Yes. And again, thank you, everyone. Thank you, Troy, and enjoy the rest of your day. I will stop recording, but I'll keep this up for a few moments. Troy, I did share your email, your website, and your phone number in the chat so that folks can grab it off there. Okay.
Perfect.
Okay. Thank you, everybody. Have a good one.
Thanks, everybody. Take care.